Thank you. Okay, these case discussions will be a lot of fun. There are no slides or no didactic slides here. It's all about discussion from the panel and questions from you. So as we go through the cases, we have 4 different categories, and we'll bring 4 different panel groups up here as we go along. Each group will be up here for 30 minutes with 3 cases. So each case will be 10 minutes that we can discuss and go through the nuances of the different aspects of management for the cases that are presented. They're short cases, just a line or 2, and we really want to ask you to put your questions forward so that we can bring them up, and then we'll, of course, be posing questions to the panelists as well. The topics will be management of infections and IBD on immunomodulators and/or biologics, challenges in the care of a patient who is pregnant with IBD, when and how to modify IBD therapies by either increasing, maintaining, or de-escalating biologics and immunomodulators, and also talking about potentially the future use of combining biologics. And then the last section will be controversies in the surgical management of complicated Crohn's disease, and have a great surgical panel that will be joining us. So the first group of case discussions will be around the management of infections in IBD patients on immunomodulators and/or biologics. We're glad to have Dr. Russ Cohen, Dr. Jean-Fred Colombel, David Bingen, and Ed Loftus here to join us. So let's bring up the first case here, which is going to be a 53-year-old gentleman with UC on infliximab and azathioprine, admitted to the hospital with a flare, started on IV steroids, and found to be C. diff positive. Before I go on to this case, I'm just going to give you some foreshadowing of what the others are so we can think about our conversations as we go, and then we'll come back to this case in a minute. The second case will be a 20-year-old female college student with a recent diagnosis of ileal Crohn's disease who has an abscess that we need to contend with and think about what to do with her medications. The third case will be a 26-year-old male graduate student with ileocolonic Crohn's disease who develops EBV while he's on combination therapy, thinking about how to manage that now and for the future. So let's come back to this first case. And looking to the panel, this is a 53-year-old gentleman with UC on infliximab and azathioprine, admitted to the hospital with a flare, and I put a flare in quotes for a reason, started on IV steroids, and then found to be C. diff positive. And what do we do with his medications? Before we get to what to do with his medications, Ed Loftus, I'd like to just start with you about C. diff positive and help us sort out what's a real C. diff positive, and what do we need to do when our laboratory reports to us that a patient has C. diff, that we need to figure out if this is something that we need to treat and is the main issue, or if this is just a positive test that maybe isn't relevant for this patient.
Well, I think what happened here was there was an evolution in testing. We used to do the ELISA test for toxin, and then we went to PCR. And although PCR is more sensitive, it may not be as specific, and you may be detecting patients who are colonized, not truly infected. However, in this setting, in the short term, there's no way to sort that out immediately, and I think most of us are still relying, most of our hospitals are still relying on PCR. I think there's a sense in the literature now that maybe you have to try to distinguish between true infection or a colonizer, and you might want to think about doing an ELISA, but not all hospitals are even, frankly, equipped anymore to do ELISA. And so in the short term, you want to treat this patient as if they have a C. diff infection. You're going to get them started on vancomycin orally.
Great. Russ, how important is it to do a sigmoidoscopy and see if it looks like C. diff? Is that part of the equation here in making a definite diagnosis and guiding our next plan?
Initially, I would say no. I mean, treat the patient vancomycin, and then if they are failing to respond after perhaps a few days, it might take a look. But I don't think initially you need to rush them to Flex C, because many of the patients will respond, and that may just be it.
Okay. Jean-Fred?
I don't fully agree. I think this patient, 50-year-old guy, is already on very intensive treatment. He's flaring. I really would like to see what's going on in the rectum and in the sigmoid. Not so much about C. diff, but just to have an idea of what's the endoscopic severity.
Sure. David Bingen, when I have questions clinically in my practice about C. diff, you're the one I contact. Help us understand and guide us about how to manage his medication. So this is somebody who's on combination therapy, had been doing well, now started on IV steroids, as most of our patients do when they get admitted with an ulcerative colitis flare. So guide us through your thinking. Which of these medications should come, which should go, and if you can comment on what your first-line treatment would be for C. diff here. Russ already mentioned vancomycin, which you may agree with, but what might happen from in your practice at Pittsburgh?
Yeah, I think there are going to be a few really important points here. So when IBD patients with colitis typically get admitted to the hospital, our go-to has always been IV steroids. And IV steroids are incredibly effective for helping to bring a colitis patient under control, but it's probably the worst thing you can do for C. difficile. So we saw problems a decade ago where patients were admitted to the hospital and they would languish. They'd go onto IV steroids. We would pick up a C. diff positive test result, and they would struggle for weeks and weeks and weeks on high-dose steroids. So we actually made changes in our practice patterns where we switched away from metronidazole and used the drug vancomycin exclusively, and we cut the steroids down as fast as possible. We wouldn't use maximum dose steroids, and this is, again, completely, a case series I'm describing. There's no gold standard evidence about how to do this. But we lowered the steroids based on the knowledge that to control C. diff, you actually have to make an immunoglobulin response against C. diff toxin. And steroids, as we all know, are fantastic drugs at blocking antibody formation. So I would cut the steroids in half if you know what you're up against. Try to get them off as fast as possible. Vancomycin is a preferred strategy for treating IBD patients with C. diff. I would not use metronidazole in a hospitalized patient. I think there's really good data from a couple institutions. Fidaxomicin is also an incredibly effective antibiotic that can be used, but it's oftentimes tiered on formularies, so it makes it harder to get access to. And we can talk about sort of the longer term duration of therapy as opposed to a 2-week course of therapy a little later on if you'd like, but I would get steroids down, vancomycin, and try to get this person to respond as fast as possible.
So while we've got you on the hook, can you comment on he's due for an infliximab dose in 2 days, and he's still taking his azathioprine as he comes in. There's a reflex of stopping immune suppression when you see an infection of some sort. So help us understand what you would do with those medications. Then Russ, I'll go to you after David's comments.
So, there's other things that could be here. So there was a comment earlier about doing a flex sig. I would do a flex sig because C. diff infected IBD patients are actually higher risk for getting into trouble with CMV. And Ed Loftus and colleagues at Mayo Clinic a few years ago showed that when CMV and C. diff come together, it's a really catastrophic scenario. So I would get data, I would do the procedure, I would do biopsies, I would do viral cultures, I would request stains for CMV. Azathioprine, I don't think is going to be a critical drug here. I actually like the drug infliximab in this setting, and I would again try to back off on steroids as fast as possible.
So when you say like infliximab, you mean give him his dose when it's due in a day or two?
I mean, you could potentially delay for a few days if need be until things start to clarify. But if it's a pure C. diff and IBD patient, I actually would favor infliximab as opposed to high-dose IV steroids.
Okay. Miguel, I know you have a couple questions from the audience. Maybe you can pose it to Russ, who's waiting to answer the question.
All right, so Russ, this is probably the most popular question that just came through in the last 32 seconds is FMT. So is there any role for fecal microbiota transplant in this inpatient admitted with C. diff and UC?
Well, I think that if you have someone who has recurrent C. diff, difficult to clear or repeatedly getting infected, similar to what you might do in someone who doesn't have IBD, who would you consider a fecal transplant for? Giving them the fecal transplant solely for IBD, though that's something that really should only be done in a controlled clinical setting. But if this is their initial C. diff infection, then right now I would not think about fecal transplant. I think what Dave said is right. You can see where the dust settles, start them on the vancomycin. If they're about, cut his steroids, and we don't even give the steroids if they weren't on it, if they come in with C. diff. If they're due for their infliximab, it's okay to wait for a couple of days. You don't need to give the azathioprine in the hospital. First of all, in our hospital, you have to fill out 1,000 forms to do it, and by the time the pharmacy approves it, the patient's been discharged. So the medicine doesn't wear off, for weeks, months. So that's an easy thing to stop. And then maybe reassess if things are going down the hill. And on vancomycin, the C. diff, it's probably not the C. diff. Do the flex sig, check for CMV, and go from there.
And then, Ed, do you use FMT at Mayo? But also there are a bunch of questions on how you stop the steroids if you start them. Cold turkey, do you decrease? Dave mentioned it a little bit.
I think you don't want to stop the steroids cold turkey. I think you would just reduce rapidly, I think. So let's say you had started them on 60 of IV solumedrol, maybe once you have identified the C. diff, maybe cut it to 40 for a couple days, then maybe try to cut it further if you can. With respect to the FMT, I think, we at Mayo, we do tons of FMT for recurrent C. diff. The big caveat here is in the acute IBD patient, there's definitely a percentage of patients, maybe up to 20 to 30%, who have transient worsening right after FMT. And if you think about it, you're introducing all this stool into an inflamed colon with a highly permeable barrier. So you just, I guess in the acute inpatient setting, we haven't been doing FMT, but once the patient cools off and if there's a question of a recurrence again, you could certainly consider FMT.
Okay, terrific. Just some take-home points here, and then I'll ask if you have anything else you'd like to add, and then we're going to move on to our next case. Great discussion. There's often a flare plus C. diff, so treating one or the other, as you're hearing, isn't necessarily the right thing to do. You really need to keep both. We do need to make sure we're doing it with a real C. diff infection, but you just don't know right away, and this is something that you're going to treat until proven otherwise. As you've heard from David Bingen and others, the need to minimize and eliminate corticosteroids if possible. Maybe not do it cold turkey, but bring their dose down quickly if you can and keep moving on. We need to maximize the appropriate C. diff treatment. You've heard here that there's no role for metronidazole in the hospital. I'd be curious to hear if you think there's any role for metronidazole even out of the hospital. We're using vancomycin as first line for all these patients. And then anti-TNF can be used as needed. There might be some concern about vedolizumab. I'm not sure if this is real. Maybe just a quick comment from the panel about vedolizumab, and we had seen some C. diff in the clinical trials.
From the safety paper, we reviewed all the safety data from all clinical trials. There was a very small signal, but really not significant. It has not been confirmed in clinical practice and from all big consortium. May I take this opportunity, just 1 second? I would like to ask to David, when would you consider C. diff as a kind of innocent bystander? Because we have so many patients in this country who are PCR positive, so should we treat all those patients?
So the question is, when do we want to ignore C. diff in the IBD patient? So I would say that when you're dealing with a flaring patient, a person who has diarrhea, who has what looks to be a colitis flare or a J-pouch, pouchitis episode, even patients who have ileostomies can get C. diff problems. When there's evidence of what you believe is clinical flare activity, it's really important to look for pathogens. And I would say that we are still limited at that point. I agree with Jean-Fred that there are situations where a person has had C. diff in the past and you're very suspicious about it. I see this definitely in the transplant population. Oftentimes the PSC, you see patients who have had a liver transplant are going to be on drugs like Bactrim for prophylaxis against pneumocystis. Exactly. And those patients will have what looks to be a recurrence of their C. diff. And we've done FMT with benefit, and then we've gone back to FMT and had failure. So it's hard to differentiate. It's incredibly difficult. But at this point in time, we don't have a way of distinguishing between what would be a flare of their IBD without C. diff back in the picture versus a person who has C. diff as a major synergizing or contributing factor.
Great. All right, thank you. Quick point, Russ.
Very quick point. The vedolizumab point, I would ignore. The long-term safety data that you will be seeing soon shows no increase in C. diff rates in patients on vedolizumab.
Great. Thanks for that comment. Okay, great discussion. Let's move on to the second case. This is something that we all deal with and we see fairly commonly. This is a 20-year-old female college student with a recent diagnosis of ileal Crohn's disease, a pretty long segment, over 30 centimeters, currently on adalimumab and 6-MP for about 3 months. So again, a recent diagnosis, recently just getting going on these medications, now admitted to the hospital with fevers and a 2-centimeter abscess within an ileal phlegmon. The questions are, first, what do we do about this? How do we approach it? Then, really, very relevant, what do we do with her medications, which she's in the hospital, she is on these medications as coming in, having fevers, worried about the treatment of Crohn's, but also certainly worried about this abscess. And maybe, Ed, I'll start with you, just about approach of dealing with this abscess, and who's your first phone call to?
So I think the first phone call is to a radiologist who does percutaneous drainage and ask them to look at the scan, and is this amenable to percutaneous drainage? It's 2 centimeters, so it's on that borderline. It may not be. And if not, then you want to treat with prolonged antibiotics, and sometimes you can make these disappear with antibiotics alone. but if it can be drained, then you'd go ahead and do that. The other thing you want to find out from the radiologist is if there is a stricture associated with the fistula, because if there is a stricture, you're probably heading towards surgery here. If there's no significant stricture with no proximal dilation, and you may have to do an enterography later to figure this out, then you might be able to get away with medical therapy alone.
Yeah.
John Fred.
I fully agree with Ed. The point that you need to have a long-term plan. And the long-term plan is depends on what you will find associated with this abscess. If you have you need to look at the stricture, you need to look at the length of the small bowel which is involved to see if it's a good surgical case as well, and then you will take your decision based on that.
Okay, great. David, let's assume the radiologists are able to get at this. They drain it. They think they've dealt with the abscess. A follow-up scan doesn't show abscess. Still in the hospital. The question comes, I'm due for my adalimumab tomorrow, and I'm not sure what to do with my 6MP. Can you guide us on what to do with these medications?
I have a couple thoughts. So this is a person who is actually relatively newly diagnosed on pretty powerful drugs. So they're already on adalimumab and purine analog, and they've gotten a complication fairly rapidly. So I am becoming more suspicious that this is someone who's going to probably need a surgical intervention. So I don't mind using these drugs in the context of surgery, but I would get my surgical colleagues on board fairly quickly, because one of the challenges is as we heal inflammation, scar tissue is kind of the natural history of Crohn's disease. And terminal ileal disease, the vast majority of patients who have that small bowel involvement are going to face an operation at some point. The question is when. Unfortunately, this person has already developed a complication fairly quickly. I don't really have much more to go in terms of perhaps additional powerful medications. So I think the medicines are fine. I would say diet should be kind of liquid in this early time period because of the abscess, and then perhaps having surgical opinions coming on board.
Okay, thank you. Miguel, what do we have from the audience?
So this will go to Russ, the question about is this a failure, and then Ed, as far as how long you would treat with antibiotics. So there are a series of questions that came through, and as Dave just alluded to, this is pretty rapid onset of a penetrating complication with an abscess on adalimumab and 6MP. Is this a failure of adalimumab? And if you think it is, what would you switch to? If you think it's not, what would you do next?
Well, you know, if this person had been well on adalimumab or infliximab for that matter, and then developed an abscess, that's almost always means that they made anti-drug antibodies that have no drug. But if this patient had been sick, you kind of threw them on the adalimumab and they never really got better, now they have an abscess. No, it's not a failure of the drug at all. I agree with everything that Dave said. However, I want to make clear that this person has 30 centimeters of disease, and if she goes to surgery right now, she's probably facing a temporary ileostomy. In order to decrease that chance, antibiotics. You know what? You might be able to get away without surgery in this person, but you have to explain to them why you're using the antibiotics, why they need to meet the surgeon, if they want to decrease her chance for an ileostomy. I would not give an anti-TNF in the setting of an abscess. She'd be off it at least a couple of months while she's on the antibiotics. I'd keep her on the 6MP because that's not going to matter anyway, and then go from there.
So.
Ed, I was going to ask you to comment. The reflex is often infection, get off drugs, like we talked about before. So this is a patient who also has very active disease. You had a nice report from the Mayo Clinic a number of years ago on this. Can you comment on the safety of continuing these drugs, assuming you have the sepsis under control?
Yeah, Doug Gwynn was the first author, and it was in CGH about 5 years ago. And what we found was as long as you have adequate drainage of the abscess, you can go ahead and give your therapy. And in fact, giving combination therapy had the highest odds ratio for reducing the risk of a recurrent abscess. So once adequate drainage is established, you can go ahead and give your medical therapy.
Yeah, I fully agree with Ed. We have exactly the same experience. The point again is what's the plan for this patient. If you plan for surgery, there is no need and no way to give a new injection of adalimumab because it doesn't make sense. But if you think that this is still a medical case, then I think you can continue the combo with the coverage of antibiotics. We had very good experience as well with that.
So Jean-Fred, quick questions that are coming through on the antibiotics since you just mentioned this. How long would you keep this patient on antibiotics, IV or oral?
No, very often I will start IV in the hospital setting, and then I will switch oral at least for 2 weeks.
Okay. And then there are a series of questions. Maybe I'll ask Ed this. And Ed, you have to speak as a surgeon now because I'm not sure you're going to be able to answer this. And for the surgeons in the audience, hopefully we don't offend anybody. So there are a series of questions from people asking, why are my surgeons so scared of operating on these patients once they cool down? So Ed?
I think, I think the surgeons are sensitized to perioperative complications in patients on immunomodulators and anti-TNFs, but I think it's important to recognize that for Crohn's operations, there's really no convincing evidence that being on these medications increases perioperative complications. I think for UC, for colectomies and J pouches, that might be a different story. There's a lot of conflicting data out there in the surgical literature about this. And I think once the patient is cooled off, if you think they need an operation, go ahead and do it. And sometimes it has to be a staged procedure, but that's the surgeon's decision, not yours.
I think it's an evolving field. There are now at least 5 or 6 meta-analyses on this topic with different results. I think the most convincing data were coming from Cedar-Sinai, where they were showing that what matters may be the levels, and the ultimate answer will come from the prospective study, which is run by Ben Cohen from Sinai, which is a multicentric US study, which will be prospective, then we will really know.
Wonderful. All right, great. Another important topic, great discussion. Just some take-home points that most of these came up, others not completely, but you definitely need to drain that abscess, whether it's radiology or surgery. That's what you're going at. Sometimes you can't, and you need prolonged antibiotics with serial imaging, and it could be weeks, if not sometimes even longer, when you're following these patients hoping for resolution, but you're really not. You need to control that sepsis right away as soon as you can. Steroids, again, a bigger offender than these other medications, and from what we heard from Ed and from Jean-Fred, that treating the underlying inflammation is critical, and that's what caused the problem in the first place. And so continuing their Crohn's-directed immune suppressive therapy, keeping them off corticosteroids, specifically continuing biologics, plus or minus with immunomodulators, is going to be critical for the long-term planning, which came out as very important. Then often that need for prolonged antibiotics while continuing or restarting Crohn's-directed therapy. We often overlap the two when we start, and maybe even a few more weeks on antibiotics as you're getting those Crohn's therapies going. I'm going to move on to the final case unless anyone has any critical comments here. Great. Okay, this is where we all get sweaty palms sometimes when we're talking to these young male patients and thinking about EBV. And this is I personally think, one of the scarier situations that we deal with when we have a young male patient in particular, as this gentleman who's a graduate student with ileocolonic Crohn's disease in remission for 3 years on adalimumab and azathioprine, now presenting with fatigue, headaches, low-grade fevers, lymphadenopathy in the neck, and has an EBV serology that's positive. So we need to first understand how to handle his medications, as we're worried about these medications in the setting of EBV, but then we have to think about the future as well. And is the risk period now, or is it in the future after even a prolonged time on thiopurine? So Ed, let me start with you, then I know Jean-Fred, you've had a lot of thoughts about this.
So I think, in the short term, I would probably stop both medications in the short term. You'd want to for sure see those clinical features resolve. I mean, I might not ever resume the azathioprine in this setting, and I would think, though, about resuming the adalimumab. I would be a little bit less concerned about EBV reactivation. But the question is, you'd have to work with your ID colleagues, and maybe there's some marker that you could use, maybe a viral load or something like that, that can help you guide when you could restart the adalimumab.
Jean-Fred.
I think it's a very scary case. I really would like to know what was the EBV status before starting, because as you know, I will never start azathioprine in a young male with negative for EBV because of this risk of acute lymphoma, which can be deadly. This is our experience with the sesame. I will definitely stop all drugs, and I will call the hematologist.
Great. David, so Jean-Fred mentioned checking EBV serology before starting thiopurines. I don't know that there's general agreement on this to understand what to do if they're positive or negative. Can you comment on your practice and maybe the reasoning of what you do?
So EBV is a very common virus that many people are going to get in their lifetime, and I don't think as a field we have had a standard practice at all in terms of screening for people before we go to immunosuppression. What I have experience with is the person who's done quite well on a purine analog who gets incredibly sick with an acute viral infection. And that can put someone in the intensive care unit if you're not aware of that possibility, be it CMV or EBV. So what would otherwise perhaps be a mononucleosis-like illness becomes a complete catastrophe. So as people acquire these infections throughout their lifetime, if it's occurring in the setting of immunosuppression, it can be a disaster. I don't know what the right answer is at this time. If we should always screen our patients for EBV status, I think we should have a high index of suspicion to always remember that when we're using these drugs, even at the relatively modest doses that we use in IBD, we could get these horrific lymphoproliferative complications.
And Corey, again, remember, this is by far the highest absolute risk of lymphoma in patients with IBD. This is in young males who are EBV negative, and that will get this lymphoma. It's much higher than the HT cell, it's much higher than the regular lymphoma in EBV positive patients in elderly. This is the group which is at risk, these young males who are EBV negative. And the absolute risk, I'm not talking about the relative risk, the absolute risk is by far the highest as far as lymphoma is concerned.
Thank you. Russ, lymphadenopathy, fevers, not feeling well, do we have to work hard here to make sure this patient doesn't already have lymphoma?
Well, yes. I mean, I guess if they are acutely EBV positive, you absolutely, as we said, we stop, particularly the azathioprine, and probably not restart it. But initially, if they're following the general course of someone who has, mononucleosis, and you'd want to check their liver function tests or whatever they call them these days too, because they can get, the EBV hepatitis too, and I keep a careful watch on them. This is why you need to see your patients on immunomodulators or biologics every 3 to 4 months, no matter what other people tell you. If you don't see them, you have to have a highly trained advanced practice provider to do that, and actually we provide free training for your advanced practice providers through our University of Chicago. This is a pitch for us.
Thanks. Miguel, questions from the audience?
Yeah, so there are a bunch of questions. Maybe the first to David. So, Dave, are you using azathioprine or 6-MP any longer in your males who are 25 years or younger?
So again, when we talk about IBD, we have to put it within the spectrum of the illness. I would say there are patients who need those drugs to actually control their disease. So I don't tend to take care of pediatric age patients, but there are young patients that I do take care of who I will definitely use purine analogs because the burden of illness that they're facing is more challenging. When we have discussions about what are the goals of the patient, if the person wants to avoid a colectomy, they want to avoid the chance of having a permanent ileostomy, and they're willing to accept the risk, then we make the decision to move forward with medical therapy. I think we all agree that these drugs work, but then when we use them in combination, you have an escalation of potential risk, and that has to be balanced, and it's on a case-by-case basis.
So actually, Ed, there are a number of questions that came after Jean-Fred said his EBV thing, so the board is literally lighting up. A few of them say they like your accent, by the way, but that has nothing to do with the case. Ed, are you checking EBV in your young males before starting azathioprine 6-MP, and is it only azathioprine and 6-MP that you worry about with ABV?
So I haven't been routinely doing this, and I would agree with David that I do still use combination therapy in some young males, and you have to case by case it based on the severity of their illness, and if they're sick enough, they need it. If they're not, if they're milder, then maybe use methotrexate or maybe use monotherapy, and you just have to use your clinical judgment. And recall that some of us have a different level of acuity of our practice or level of severity. So we're seeing quaternary referrals, and so I probably use a lot more of this than maybe other people. But there is definitely a role, I think, for combination therapy in some of these young male patients.
With my French accent, I respectfully disagree. I think
It sounds nicer when you say it that way.
I think, again, the absolute risk of lymphoma induced by azathioprine in a young male, which is EBV negative, is the highest absolute risk ever. You can just look at the Sesame data and data from Laurent, it's very clear. And we have alternative. You can start this patient with methotrexate. And I guess this is why pediatricians are not using azathioprine anymore in combo therapy.
Well, it's clearly not 100% agreement on this, and I still think there's more to learn on this topic. Some take-home points that we can take is consider checking EBV status beforehand. I think you can certainly learn something, be reassured if it's positive, if it's negative. We certainly have had some good discussion about the absolute risk. And although it's still fairly low, higher than what we've seen with other cases of lymphoma where we're already shying away from. So if you're going to stay away from azathioprine, particularly in young male patients, this is the scenario to do it. I will warn you that the data on methotrexate just isn't there as far as safety with combination therapy with any patients. But if you look in the rheumatology literature, although they do have a higher baseline risk of lymphoma, they have a series of patients who have methotrexate-induced lymphomas that are large B-cell lymphomas that are EBV-mediated. So I don't know that methotrexate is definitely the safe answer here. It's still immune suppression. It still modifies EBV replication, and something that we need to think about more carefully as we move forward. Holding immune suppression while recovering from EBV, clearly following the clinical status to guide when to restart immune suppression. Immunomodulators such as thiopurines or methotrexate are likely to be the offending medication. I think you've heard from the panel here that we're not too concerned about biologics in this setting. And then restart the biologics as soon as you're possible, but there's really has to be a very careful discussion about restarting thiopurines in the future. In my practice in this patient, I'd probably avoid thiopurines and go with biologic monotherapy. So I'm going to thank the panel. We're going to move on to section number 2, and thank you for a great discussion.